Thank you, Shesh. Good evening, everybody. It's a very proud moment today to be hosting the 197th webinar of ICA. As you all know, we've been conducting webinars every Wednesday continuously and consecutively, and within 3 weeks, we'll be celebrating our second anniversary. So we are really, really honored, and we've had always such good faculty that all our webinars are doing excellent. For the viewers to know that we will be celebrating our 5th International and 15th National Conference of the Indian College of Anesthesiologists in Lucknow in September this year. And you can see in this group that how you can log on and how you can do the early registration for the conference. So you all are most welcome. We have a very extensive workshop, one whole day, a session for the paramedicals also, plus many plenary lectures and panel discussions for the youngsters and the students. We have a yearbook of anesthesiology, which we publish every year. And this is available online at www.pustakbhandar.com. And we have published the 13th edition last year, and we shall be publishing and releasing the 14th edition in September this year. So knowing a few of these activities of the Indian College, today we have a very interesting webinar on oxygenation. I don't think we've had one in this topic in our webinars. Very important topic, and we are very happy that Dr. Moeed Ahmed, the past chairman of the Aligarh Medical University, Moeed, and he will be the moderator today, and he will be moderating the faculty that is included, are very, very senior faculty and good colleagues of the ICA. So Moeed, I think please go ahead, and thank you so much for joining this webinar. Thanks a lot.
Thank you so much, Madam, for the introduction, and good evening to you as well. I, on behalf of the Indian College of Anesthesiologists, welcome you all in this webinar. And obviously, it's a very interesting topic, as Madam has already said, oxygenation, which is one of the most important component of survival. If you don't have oxygen, obviously, you are always in a crisis. So every aspect of oxygen will be dealing today, starting from the cell level of oxygen, the demand and supply, followed by the target which you need to achieve to maintain a balance. Subsequently, how are you going to deliver this oxygen? And finally, what is most important implications of this oxygen when we talk about the anesthesia component, especially when we are talking about the airway management, and which is one of the buzzword today, that is para-oxygenation. Nowadays, we are no more talking about pre-oxygenation only. It is all throughout, which is peri-intubation oxygen. So that we'll be talking about today as well. So over to you, Dr. Anil Verma. Professor Anil Verma is again a professor in the Department of Anesthesiology, Kanpur, GS Medical College, Kanpur, and I think he will introduce himself in the first slide. Thank you so much. Over to you.
Thank you very much, sir. Good evening to all of you, and my regards to Madam Sood, because under her guidance, I have done many of the conferences as well as delivered lectures, and she always obliged us by her presence in any of the state conferences under leadership of Dr. Moeed. So thank you very much, Madam. So it is a great opportunity to talk over this Indian College of Anesthesia platform webinar, and definitely this topic given to us is very interesting. It is oxygenation, though we consider that oxygenation is quite simple, but the oxygenation is nothing just a method to assess the pulmonary function, but it is also a surrogate marker for assessing the cardiovascular function. So let us start off with our okay, is my slides moving? No.
It's not moving.
Okay, let me try to share once more.
Yes, sir, we can see your slide.
First slide is visible. Change it. Let me see. Yeah,
Yeah.
it's okay. It's okay.
It's
Yes, sir, it's moving.
fine, sir. So let me start what is with the concept of what is the oxygen delivery, because as we know, the oxygen is a gas of life. So every cell requires, for all the metabolic activity conducted in the cell, the oxygen is an important component of it. And whenever there is a compromised oxygen delivery to the tissue, the overall metabolic activity as well as the functions of the cell will be compromised. And most of the time, it is the oxygen delivery to the tissue is compromised in case of a shock. If we talk something about the shock, initially it was considered that just having the mean arterial blood pressure less than 60 or the systolic arterial pressure less than 90 or drop in the systolic arterial pressure more than 40 millimeter of mercury was considered to be shock. No, it is not so. Basically, the blood pressure, the main aim of the blood pressure is to deliver the oxygen to the tissue. So the present consideration is whenever there is inability to fulfill the oxygen requirement to the tissue, then it is considered shock. And that means there is an improper match between the delivery of oxygen as well as the consumption of the oxygen. So here the two terminology has came into picture. One is the delivery of oxygen, second one is the consumption of oxygen. So if first we need to understand what do we mean by the oxygen consumption. Oxygen consumption is represented with VO2. So delivery of the oxygenized tissue is by DO2, which is mainly dependent on the cardiac output as well as the oxygen carried by the blood in the arteries, whether it is bound to the hemoglobin or it is dissolved in the plasma. And second component of this consumption, oxygen consumption, is the oxygen extraction by the tissue, and that depends mainly by the extraction capacity of the tissue or the oxygen demand of the tissue. So the consumption based on delivery as well as the extraction of the oxygen by the tissue. So just we plot these values on the formula. That means the consumption of oxygen is equal to extraction of oxygen multiplied by delivery of oxygen. So there could be the two different views. One, what is the oxygen consumption, what we are observing. Second, what is the oxygen consumption, what is actually needed. So the oxygen needed as well as oxygen observed should be equal. If there is any deficiency in the oxygen delivered or the observed, then needed. That means that tissue is suffering from dysoxygen. So oxygen observed can be calculated by the oxygen extraction observed as well as and the oxygen the delivery of oxygen observed. Whereas the needed can be calculated, needed oxygen consumption can be calculated by the needed oxygen extraction and needed delivery of oxygen. So ratio must be 1. If you see, the delivery of oxygen depends on the two major factors. One is the cardiac output, second is the oxygen concentration in the blood, which based on the hemoglobin as well as saturation of oxygen and the partial pressure of oxygen in the blood. So the formula is given here: cardiac output multiplied by hemoglobin into 1.34 multiplied by SaO2 plus the 0.003 multiplied by partial pressure of oxygen. So if you go through this diagram, it is very clearly shown that the threshold of the delivery of oxygen is near about 100 ml per minute. If the threshold goes down, from drop down from 100 to towards the 0, there gradually the oxygen consumption also goes down because the available oxygen is less available to the tissue. So the threshold values of the delivery of oxygen should be maintained 100 ml per minute minimum. The whole body oxygen consumption doesn't match and confirm every organ perfusion because there is a metabolic and distributive mismatch. So always when we want to maintain the microcirculation or the oxygen delivery to the tissue and most of the tissues, organ system as well as tissue, first we need to maintain the macrocirculation so that at least the baseline circulation is maintained. Now the microcirculation can be achieved further. Now the second component is the oxygen extraction that can be calculated by simple cardiac output multiplied by the difference between the oxygen at arterial side to the venous side. And if we just keep on calculating this formula and we find that in the same patient, the cardiac output as well as hemoglobin multiplied by 1.34 is almost a constant. So the extraction of oxygen is directly proportional to the saturation of oxygen, difference between the saturation of oxygen at the arterial and the venous side. And indirectly, just to further solve this equation, that the saturation of the oxygen at venous side is directly proportional to the oxygen at arterial side as well as the extraction of the oxygen. Therefore, this venous oxygen saturation can be taken as a surrogate marker of the oxygen extraction at the tissue level as well as the oxygen consumption. So SpO2 is very good marker in that case. So so what we call the good resuscitation, when the clinical condition of the patient improves as well as there is improvement in the oxidative metabolism in the tissue. That means there is no anaerobic metabolism, and the anaerobic metabolism is always represented by the presence of lactates. So if lactates are not present in our blood, that means our tissue is well perfused, there is no anaerobic metabolism. Still, the lactate cannot be a confirmatory marker for the tissue perfusion because it is affected by so many factors like diabetes mellitus, liver dysfunction, tissue reperfusion, catecholamines, cellular metabolic alteration, and inhibit pyruvate dehydrogenase. So we need to we need a certain other surrogate marker which can give us an idea about the oxygen the perfusion of the tissue and the oxygen consumption by the tissue. Whereas, so in this case, because the need as well as observed oxygen consumption ratio should be 1, and the need of the oxygen consumption can be affected by few of the clinical conditions, like in the increase in the temperature at every 1 degree Fahrenheit, there is 13% increase in the oxygen consumption, whereas in sepsis, it may rise up to 0.7 to 3-fold, and it can only be improved by reducing the metabolic requirement, as in case of a seizure disorders or shivering, there may be increase in the oxygen consumption. In that case, we can suppress the seizure or we can reduce the shivering, then the decrease in the metabolic requirement. Optimizing the hematocrit, at least minimum hematocrit to deliver the oxygen to the tissue should be at least 25 in non-cardiac patient, and the cardiac compromised patient, it should be managed up to the 30. So optimizing the arterial hemoglobin oxygen saturation by supplementing the oxygen so that maximum oxygen can be carried by the hemoglobin, and improving blood flow, that is improving the cardiac output. So in case of if there is any increase in the VO2 or the oxygen consumption, if the delivery of oxygen goes down, then the critical limit, that the threshold less than 100 ml per minute, there is a rapid fall in the oxygen consumption, and patient may be in the zero oxygen consumption state, which is almost similar to the situation of a shock. That means the oxygen delivered to the tissue is not adequate. So this oxygen consumption is inversely related to the cell dysfunction, the necrosis, and the severity of shock. So our main target is to establish the oxygen consumption as per the metabolic need of the patient. And the indirect or the surrogate marker for the assessment of this oxygen consumption at the tissue level, one is the cardiac output. If the cardiac output is adequate, that means the perfusion of the tissue and the delivery of oxygen through that perfusion is adequate. And second, what is the SvO2? As we have already seen, the SvO2 is directly proportional to the SvO2 as well as the cardiac output. In this particular study, they have clearly shown if the SvO2 value is less than 70% at up to the 6-hour, overall 90-day mortality is dramatically increased, and if the SvO2 is maintained above 70%, then the mortality has been reduced. And most of the time, it is all because of the cardiac dysfunction. The difference between these two oxygen values, the SvO2 sample collected from the pulmonary artery, where the ScVO2 is collected from the superior vena cava, and the deoxygenated blood which arise from the upper extremities, lower extremities, and the coronary sinus, that is included in the SvO2, whereas the coronary sinus is excluded in the ScVO2. For the ScVO2, we need a central line. For the SvO2, we need the pulmonary artery catheter, and the SvO2 normal value should be more than 65%, where the ScVO2 should be more than 70% values. But there are certain limitations for the SvO2 values, where we need a central venous catheterization. That is a partially invasive technique, and the risk of hemorrhage and the infection could be there. And the tip of the catheter should be accurately placed at the junction of the vena cava as well as the right atrium. If the tip of the catheter is not placed, then there may be little bit difference in the values. So values. This SvO2 value gives a global assessment of the tissue perfusion. It is not an organ specific, and the local delivery of oxygen and the consumption of the ratio between delivery and oxygen consumption for local tissue or the local organ system cannot be assessed by this. There are many other methods by which we can check for the local tissue oxygenation, like the infrared spectroscopy, where we can check for the saturation of tissue oxygen, and that can be seen. The Another method, what we can assess the perfusion status, that is by the carbon dioxide gap. How much the carbon dioxide produced and how much is carried by the perfused blood. So, but still it is in the misinterpreted in septic patients, specifically the carbon dioxide gap, because there is a decrease and the SVO2 values, because there is a decreased oxygen extraction by the tissue. So the SVO2 values may be high in that case. Increased shunt fraction. So the carbon dioxide gap is not adequately presenting the picture what because of the decreased perfusion pressure, perfusion of the tissue will be there, and most of the time the oxygen affinity for the hemoglobin is also altered, which can be which will be told you in the next lecture while explaining the oxygen hemoglobin association curve. So the SCVO2 is very much informative regarding the cardiac output, specifically in the circulatory shock. The SCVO2 should be done in mainly the non-responders. And when there is non-responder patients are present, the dobutamine can be taken as a treatment to increase the cardiac output. If there is no shock, and so don't correct the SVO2, because in that case you may either unnecessarily starting with the inotropes or unnecessarily giving the fluid, and the patient will end up into the volume overload. So how can we proceed with the patient where the decreased oxygen consumption, where the delivery of the oxygen as well as the consumption of the oxygen is mismatched, and that is presenting as a status of a shock? First, give the fluid challenge to the patient. We can start with the vasopressor, so to maintain the mean arterial pressure at least 65. If the tissue perfusion is adequate, and which can be checked with the help of SVO2 values, we can go for the lactate values, and we can also try for the carbon dioxide gap. If the tissue perfusion is perfect, then we can again start with the de-escalation of the therapy. If it is not adequate, then again consider the second fluid challenge. We can increase the mean arterial pressure to achieve the mean arterial pressure, and we can go for the SVO2 value. If it is less than 70%, then try to increase the delivery of oxygen either by increasing the SVO2 values, by increasing the oxygen saturation of the, increasing the partial pressure of oxygen at the, of oxygen in the arterial side, as well as increasing the carrying capacity by transfusion blood, or improving the hemoglobin saturation. And we can try for the increase in the cardiac output by fluid challenges. Dobutamine or nitrates can be used, though fluid challenge and dobutamine is preferably used in that case. So if the SVO2 values is more than 70%, then simply go for the carbon dioxide gap, whether it is more than 6 millimeter of mercury or less than. If it is less than 6 millimeter of mercury, that means the delivery of oxygen is almost adequate in the patient. And if it is more than 6 millimeter of mercury, then again try to increase the delivery of oxygen by with the help of increasing SVO2, hemoglobin transfusion, or increasing the cardiac output. So this is how the oxygen is delivered, and what is the importance of the delivery of as well oxygen as well the consumption of oxygen. It not only gives us an idea about the pulmonary system, whether the oxygen diffusion is adequate and the oxygen carrying is properly at the pulmonary level, but it also gives the idea about the cardiac output and tissue perfusion, which is a standard method to assess the shock. It is not simply the reduction in the blood pressure, it is the compromised tissue perfusion and utilization of the tissue level. Thank you.
Thank you, Dr. Anil. It was an excellent, the way you discussed the requirement of demand and supply, which is what will happen if you don't supply, and the various ways how you can assess. At the same time, it is not always the oxygen which is responsible. Of course, the blood supply, that means the hemodynamic status, is as equally important when we talk about the supply and demand. Now we have the next speaker, Dr. Abu Nadeem, who is an associate professor in the Department of Anesthesiology and Critical Care, Jain Medical College, Aligarh. Over to you, Abu Nadeem. We'll be talking about oxygenation, its target and balance. Abu, are you there? Abu Nadeem? Is he there?
I think he is not connected, sir.
He was connected. He said he's connected.
Maybe disconnected somehow.
Right. Okay. I think he needs to be allowed. Who's there? Momita, who's there in TrendMate? Anyone? I think he's not being.
Sir, link is there. Link is there. He can join. He has joined before also.
You can join through the link, Abu, if you need me. You have the meeting passport and code, meeting this thing also, ID also.
Has he joined from the faculty link or by mistake by delegate link?
Delegate link तो नहीं join करा. Hello.
We can go for the next lecture, and I will. By the time I will contact him. He is here, sir. He is here. He has joined. He has joined.
Yeah.
Yes, sir. I was listening to the lecture from today's link, but this is the yesterday link you have shared.
We can go for the next lecture, and I will. By the time I will contact him. He is here, sir.
He is there. He is
Already
there.
I have joined.
So you can.
Okay, I will start sharing my slides.
Yeah, yeah.
Yes, sir. I was listening to the lecture from today's link, but this is the yesterday link you have shared.
We can go for the next lecture, and I will
No.
contact him. He is here, sir.
He is there.
Okay, I will start sharing my slides.
Sir, can you please close the tab from which you have joined from the delegates link, the another tab, because the voice is echoing.
The voice is equal, exactly. So
Now I'm audible to all, or what? There is any problem?
now it is not problem. I think you can go ahead. What do you say more? Who's there?
Should I start?
Please close the tab from which you have joined from the delegates link, the another tab.
You remove yourself from the exit from the delegates link. Abu.
You are telling to me.
Yeah, I'm telling you, Abu, you exit from the delegates link.
If I will close this tab, then I think I will be out of this meeting. Should I start?
No, I
So
think
we are sharing link with you to join the thing.
I think you can carry on. There's no echoing. There's no echoing as of now.
You are telling to me.
Yeah.
Yes, sir.
From the delegates link.
If I will close this tab, then I think I will be out of this meeting.
Yeah, there's an echo. That's what I'm saying.
I will.
Yeah, that's it. Mahima is there with us?
I'm here.
Yeah, he has come. He's coming. He's there. Shall we start? Are you sharing, Abu? Hello? Unmute karo, Abu. Unmute yourself.
Hello.
Yeah. Start it, then start.
Abu sir, unmute yourself, please.
Abu, unmute yourself. Full screen. Okay.
Okay.
Abu sir, unmute yourself, please.
Unmuted. I am audible to all.
Yeah, you're audible.
Okay, now I will start. Is it okay?
It's okay.
Okay, well, I'm Dr. Abu Nadeem, Associate Professor in the Department of Anesthesiology. I will be speaking on tissue oxygen targets, finding the balance.
Sir, unmute yourself, please.
Unmuted. I am audible to all.
Yeah, you're audible.
Okay, now I will start. So the aerobic metabolism
Okay.
requires oxygen to produce energy in the mitochondria. Sir, it is echoing. I don't know whether it is audible to all or not. Tissue oxygen targets, finding the balance. Sir, I am audible because it is echoing and it is
Sir,
reverting back to me.
you need to leave. Sir, you need to leave from the another
Why?
link which you have joined previously.
Sir, it is echoing. I don't know whether it is audible to all or not.
Firstly, leave from this link and then come to the faculty link.
Dr. Abu,
Yes, sir.
am I audible to you? Actually, you have
I'm
joined
audible,
from two
because it is
different links.
going and it is
Sir,
reverted back to
sir,
me.
you,
दो लिंक से ज्वाइन करा है, तुम एक लिंक ऑफ करो, निकल जाओ उस लिंक से. Switch off from one link, then come to the faculty link, which I've sent in the morning. Meanwhile, I think Mahima, if you're ready, I think we can talk on this.
Yes, sir.
So I'll share my slides.
Mahima is there. Yeah, he's there. She's there. Yeah. Yeah. Okay, Rabu. Chalo. Full screen karo.
So
Yeah.
is it visible?
Is it visible? It's visible.
So good evening, everyone. I'm Dr. Mahima Lakhanpal, Associate Professor, Department of Anesthesia from Santosh Medical College. So now we learned about the oxygen supply and the demand. So now we will study about how we can give oxygen to the patient. So I'll be talking about the oxygen delivery devices. Now, oxygen therapy is the administration of oxygen at concentration which are greater than that in the room air to treat and prevent hypoxemia. And the oxygen delivery devices, they are the devices which are used to administer, regulate, and supplement the oxygen to the subject to increase the arterial oxygenation. Now, the choice of the delivery system will be based on a degree of hypoxemia, the requirement for precision of delivery, the patient comfort, and the cost. So in oxygen delivery system, in normobaric system, we have a low dependency, medium dependency, and high dependency system. So what is this dependency system? In low dependency system means that the patient has spontaneous breathing pattern and he has slight mild hypoxia. So only a low dependency device can be sufficient. In medium dependency, supplemental oxygen has to be given. Along with this, the patient also requires some degree of respiratory assistance. So example is CPAP or the BiPAP device. And in high dependency, patient requires supplemental oxygen along with the full respiratory support, like the ventilator support. So in low dependency, we have the low flow system, which is also known as the variable performance system, and the high flow system, which is known as the fixed performance system. In low flow, we have nasal cannulas, simple mask, reservoir mask, and in the high flow, we have the Venturi mask, FNC, or the blenders. So low dependency system has variable performance devices. So why it is called variable performance devices? But because it does not deliver a fixed FiO2. It depends on the flow rate, inspiratory flow rate of the patient. Whereas in the fixed performance device or the high flow devices, the FiO2, it is fixed. So what is the difference between variable and the fixed performance? In variable, we cannot deliver a constant FiO2, whereas in the fixed, we have maintained a constant FiO2. In variable, the flow rate has to be lower than the inspiratory flow rate of the patient, whereas in the high, it is more than the inspiratory flow rate of the patient. So in variable, the final concentration of the oxygen will depend on the ventilatory demand, the size of the oxygen reservoir, and the rate at which the reservoir is filled. Whereas in the fixed performance, it does not depend on any of the patient factors. In variable, the degree of dilution with the room air, it will depend upon the inspiratory flow. It is not fixed. Whereas in the fixed, even the entrapment of the room air, how much room air is being entrapped, that is also fixed. In variable, the rebreathing may occur, whereas in the fixed performance, the rebreathing is avoided. So examples of the variable are nasal prong, oxygen mask, and in the fixed is the Venturi mask, HFNC, or the oxygen blenders. So first we'll deal with the variable performance devices. First is the nasal prong. It is the most common used device in mild hypoxia. And here the reservoir is the nasopharynx and the oropharynx, which has a capacity of 50 ml. We can keep the flow from 1 to 6 liters per minute, and the maximum of 46% of FiO2 can be delivered for this. So this table shows that as we increase the flow rate from 1 to 6 liters per minute, with every 1 liter per minute increase in the flow, the FiO2 will increase by approximately 4%. So the maximum that we can give with the nasal prong is at 6 liters per minute, that is 0.46 of FiO2. And in the other table shows that as the minute ventilation increases, even if the flow is high, the minute ventilation increases. So with minute ventilation, there is entrapment of the room air. So if the patient is hyperventilating, the flow rate is less, so the room air will be entrapped and the FiO2 will decrease. So at 6 liter per minute, if the minute ventilation is 20 liter per minute, automatically the FiO2 will decrease to 0.32 from 0.6. So what are the advantages? It is convenient for the patient because the patient can talk, eat. It is cheap and it is easy to use. It can be used in apneic oxygenation also. Whereas the disadvantages, it causes dryness of the nasal mucosa. We cannot achieve a very high concentration of oxygen, especially in patients who have a high minute ventilation, and it can dislodge patients who have polyp or septum. Even in that patient, they are not very effective. Then the other device is nasal catheter. It is a single Newman catheter. It has small holes at the tip and the size is around 8 to 14 French. It the tip of this catheter will lie above and just behind the uvula. It can give a FiO2 of 40%, but it is not very much used because it has no advantage over the nasal cannula. And moreover, if it goes deep, it can cause the gastric distension also. Then the next device is simple mask or the Hudson mask. It adds to the oxygen reservoir by 100 to 200 ml. And we can keep the flows to 5 to 10 liter per minute, and a maximum of 60% FiO2 can be achieved. It fits, it has to fit to the patient's mouth and the nose, and it has some expiratory ports through which the expired air and the carbon dioxide can come out. It can be humidified also, therefore nasal mucosa dryness or oral mucosa dryness can be prevented. So what is the advantage? It can provide a high maximum FiO2 than nasal prong. It is cheap and easy to administer, but the disadvantage is eating and drinking can be difficult. It requires a tight seal, which can be uncomfortable for the patient. Patient may feel claustrophobic, and we cannot achieve a high concentration of inhaled oxygen in patients with high minute ventilation as in nasal prong, and the chances of rebreathing are also high. Then the next device is the mask with the reservoir bag. Now there are two devices, that is the partial rebreathing system and the non-rebreathing system. In partial rebreathing system, a reservoir bag is added, which again adds to the capacity of the oxygen reservoir by 600 to 1000 ml. And it can deliver an FiO2 of maximum 0.8. Now the bag has to be kept inflated in order to give high FiO2 and to prevent carbon dioxide rebreathing. And for that, the minimum flow should be 18 liter per minute. Now, why it is called a partial rebreathing system? Because there is no valve between the mask and the reservoir bag. So when the patient starts exhaling, the air from the upper airway will reach to the reservoir bag. But since it is an anatomical dead space, it will contain more of oxygen and less of carbon dioxide. Now, when the expiration, it continues. So the expiratory flow rate will gradually decrease and it will become lower than the oxygen flow. And at that point, the expired air will stop coming to the reservoir bag and it will go out through the expiratory ports. So only a little amount of carbon dioxide is rebreathed. So what is the advantage? The inspired gas is not mixed with the room air, thus greater ability to control composition of inhaled gas. And the disadvantage is, again, it requires a tight seal, may be uncomfortable for the patient. It interferes with eating and drinking, and aerosolized bronchodilator therapy is not possible with this. Then we have the non-rebreathing system. Again, like with the partial rebreathing system, we have a reservoir of 1000 ml. And in this, there is a valve between the mask and the reservoir bag. So all the expired air, it goes through the expiratory ports. They do not enter the reservoir bag. So a high FiO2 can be achieved around 95 to even 100%. So the flow rates to be kept 10 to 15 liter per minute, and the bag should be kept inflated throughout the respiratory cycle. So this is the diagram of the non-rebreathing mask. Advantage is again highest possible FiO2 without intubation, and it is very suitable for spontaneously breathing patients with severe hypoxia. And the disadvantage is it is slightly expensive, requires a tight seal, again interferes with eating and drinking. It is not suitable for long-term use, and malfunctioning can cause suffocation or CO2 buildup. Other devices that can be used in intubated patient or tracheomized patients are the TP system or the tracheostomy mask. So these were the variable performance devices. Now we come to the fixed performance devices. Here we have the air entrapment devices, the high flow nasal cannulas, and the oxygen blenders. So air entrapment devices, they work on the principle of Venturi principle or the Bernoulli's principle. Here in Venturi mask, the flow of oxygen is low, but it is made to pass through a very small orifice. So when it passes through a small orifice, as per the Venturi law, it produces a high velocity and a viscous drag. As you can see in the diagram, a viscous drag is created. So this viscous drag, it causes the air entrapment into the mask. And this air entrapped, it depends upon the size of the port, which is fixed in all the Venturi masks. So these are the ports. They are color coded, and specifically the flow at which they can be operated is mentioned on these ports, and how much FiO2 is delivered is mentioned. Another way is that we can adjust the FiO2, and even the entrapment ports are fixed. If we are delivering a patient, giving a patient an FiO2 of 35%, the entrapment port will be fixed, and a fixed amount of room air will be entrapped in that case. That is why it is known as the fixed performance system. So a Venturi mask will allow a precise measurement of FiO2. It utilizes different size ports to change the FiO2. Maximum of 60% can be given. The FiO2 and oxygen flow, they are clearly stated on the bottom of each port. It does not cause dryness of the mucosa, and the patient can easily talk, but it can interfere with the talking and the eating. It is particularly useful in COPD patients where a precise oxygen delivery is crucial, and inability to deliver the high concentration of inhaled oxygen is there. The other high delivery system is the high flow nasal cannulas, which we have used in the COVID patients also. So here it is a nasal cannula through which we can deliver 100% oxygen with a high flow rate, that is 60 liters per minute. So we can start with low flow rate up to from 30, and we can exceed up to 60 liters per minute. And we can set the temperature also from 31 to 37 degrees Celsius. So we get a heated and humidified air. So on this principle, we have Thrive, that is the transnasal humidified rapid insufflation ventilator exchange, which is a technique that is used warm humidified oxygen is administered by a high flow nasal cannula and achieves an apneic oxygenation and ventilation. So a flow rate of 60 liters per minute can be put, a heated and humidified oxygen can be delivered by this method. And what are the advantages? It will prevent the drying up of the oral and nasal mucosa. It improves the ciliary function with the removal of secretions. And because a high flow is being given, it gives a flow-dependent positive airway pressure and prevents the atelectasis of the airway and the alveoli. And it eliminates the carbon dioxide also. Then the other method is oxygen blenders, which are compact, they are lightweight devices, and they allow the mixing of the medical grade oxygen with air within the blending unit. So when air entrapment devices, they cannot deliver a high FiO2, these blenders can be used. They can deliver a FiO2 up to 100%, and a flow rate of more than 60 liters per minute can be given. They allow precise control over both FiO2 as well as the total flow of flow output. They are used in patients who need high FiO2 and have a high inspiratory demand also. So these were the low dependency oxygen delivery systems. In medium dependency oxygen delivery system, we have the CPAP and the BiPAP. So in continuous positive airway pressures, we introduce a airway pressure which will maintain a continuous pressure and keep the airways open. So it is a way of delivering PEEP, but it can maintain throughout a continuous speed throughout the respiratory cycle, and it will prevent the atelectasis and improve the oxygenation. It can deliver via the face mask or the nasal mask. Then the bi-level positive airway pressure, the difference in CPAP and the BiPAP is that here we are fixing two pressures. We have the inhalational pressure, that is the IPAP, and the exhalation pressure, and thus the airway as well as the alveoli can be prevented from collapsing while throughout the respiratory cycle, and it can cause the oxygenation and also improve the respiratory effort of the patient. So what are the advantages? They can postpone the intubation in acute respiratory failure, can be used in obstructed sleep apnea. The disadvantages, they are tight fitting masks, uncomfortable, patient cannot eat and talk, mask may cause irritation or redness of the skin, and even abdominal distension, which can lead to nausea, vomiting, and aspiration. Now, how do we select the devices? They are dependent on the 3 Ps, that is the purpose, the patient, and the performance. So the goal is to match the performance characteristics of the equipment to both the objective, that is the purpose of using that device, and the patient's special needs. Then the purpose is to improve the arterial hypoxemia, and the patient factors are severity, how much severity and the cause of hypoxemia is there, what is the age of the patient, what is the degree of consciousness and alertness of the patient, stability of minute ventilation is there or not, whether the patient is a mouth breather or a nose breather. And then on the performance, we see whether the desired FiO2 level is low, whether we desire less than 35%, according to that, we will choose the device, whether the desired oxygenation is 35 to 60 or it is high. So the take-home message is an appropriate selection of oxygen device depends upon the degree of hypoxemia, on the underlying condition of the patient, and anesthetists and all the physicians, they should be well aware about the devices and their functions. Thank you.
Thank you, Dr. Mahima. It was an excellent, very crisp talk on the delivery systems, oxygen delivery system, and how do you deliver, and what should be delivered when. Specifically, we must know that how much to be given and how to be what should be the equipment which should be used for what particular person. Thank you, and over to you, Dr. Abu Nadim, once again. I think you're logged in. Yeah, so you can carry on.
So, thank you, sir. So I will be speaking on tissue oxygenation, oxygen targets, finding the balance. Aerobic metabolism requires oxygen to produce energy in the mitochondria, known to all of you. Hypoxia refers to situation where there is lower than normal oxygen partial pressure in tissues, and this may arise from hypoxemia, that is low oxygen content in the blood, impairment of the oxygen deliveries to the tissue, for example, the cardiac failure, and the impairment of cellular uptake or of intracellular utilization. That is, the mitochondrial level, the mitochondria are not able to utilize the delivered oxygen. Whereas on the other hand, hyperoxia is not harmless. Range of undesirable physiological and cellular effects, including absorption atelectasis, can occur with hyperoxia, intrapulmonary shunting, delayed recognition of clinical deterioration. That is, pulse ox applied to the patient, it will detect lately if the patient is hyperoxic. So now let's discuss what type of balance we need to maintain in the patient, and basically in the critically ill patients. There is an increasing evidence that hyperoxia may be harmful in critically ill patients. Let's go back to 2015 and start from there. Helmer-Horst et al. Published a systemic review and meta-analysis of cohort of studies of the association between arterial hyperoxia and outcome in critical illness or critically ill patients. And what he has concluded, that in subset of patient, hyperoxia was associated with worse outcome. Now let's see what happens in 2016, Oxygen ICU. A single-centered randomized trial of 434 patients reported a lower mortality, that is 11.6% in the conservative protocol for oxygen therapy. What is conservative protocol? That is maintenance of the arterial PaO2 of 70 to 100 millimeter of Hg. There is difference in the studies, in the trials, because the conservative protocol, or basically there are three things: hyperoxia, conservative protocol, and the normoxia. And different studies, they have taken the different values for this hyperoxia and the conservative protocol. I will discuss in subsequent slide. So in conservative protocol, the PO2 of 70 to 100 millimeter of Hg is maintained, or high arterial hemoglobin oxygen saturation measured by pulse oximetry is 94 to 98%. They have compared this conservative protocol with the hyperoxic protocol, in which the PaO2 was 150 millimeter of Hg and SpO2 of 97 to 100%. What they have found in 2016, that the mortality in the conservative protocol is 11.6%, whereas it is increased to 20.2% in hyperoxic protocol. So what happens in 2017? HYPERS 2S trial randomized 442 patients with septic shock on mechanical ventilation to normoxemia or hyperoxia. Now, what they have observed, the 28 days mortality was 43% in hyperoxic group versus 35% in the normoxia group. In addition, that is, hyperoxia is dangerous, what they are trying to emphasize. In addition, there was a significant difference in serious adverse event in the hyperoxia group compared to the normoxia group. The trial was stopped early due to safety concern. What happens in 2018? A systematic review and meta-analysis of Chu et al. Concluded that conservative oxygen goals were associated with better outcome and that liberal goals were associated with increased mortality. So what we have seen till now, that is up till 2018, what they have said, and they are emphasizing that the conservative oxygen protocol is better than the normoxic and the hyperoxic protocol. But what is next? Now, when we come to 2019, in contrast to the previous studies in the Cochrane review, Barbatos-Kovic et al. were uncertain about the effect of higher versus lower supplemental oxygen in adults admitted to the ICU, and were not able to draw any definitive conclusion whether hyperoxia is better, normoxia is better, or conservative therapy is better. What happens in 2020? Two randomized trials were published in the same 2020 issue of New England Journal of Medicine. The ICU ROCKS trial investigated the number of ventilator-free days up to 28 days from randomization between conservative oxygen group, that is SpO2 of 90 to 96%, and usual oxygen 90 to 100%. There was no significant difference in primary outcome of number of ventilator-free days. There were no differences in secondary outcome of 90 and 180 mortality, cognitive function, or health-related quality of life. So, what is their conclusion? They suggested that there is no benefit of conservative oxygen therapy. Now, the paradigm is changing from 2018 to 2020. Now, what is coming out? It is coming out that the conservative oxygen therapy or the strategy is not beneficial as compared to the hyperoxic or the normoxic oxygen strategy. In the same year, LOG-O2 trial examined whether conservative oxygen therapy and liberal oxygen therapy resulted in a difference in primary outcome of death of any cause at 28 days. What they have found, in 205 patients mechanically ventilated for acute respiratory distress syndrome, were randomized either to conservative therapy of PO2. Now, look at this. Now, the conservative therapy, what they are saying, it is 55 to 70 millimeter of Hg, with SpO2 aiming 88 to 92, or liberal therapy of PO2 of 90 to 105 millimeter of Hg with SpO2 of 96%. Because in this trial, the conservative therapy has gone further down from less than 70%. What I have seen from the different trials and concluded that these three criteria are: the conservative therapy is 55 to 70 millimeter of Hg of PO2. The normoxic therapy is 70 millimeter to 100 millimeter of Hg of PO2. And the hyperoxic therapy is a PaO2 of more than 100 millimeter of Hg. This is what I have concluded from the different trials and the studies. So after 28 days, there was a significant difference in the mortality of any cause, that is 34%, nor death at 98 days. Now, there was no significant difference. There was an increased incidence of mesenteric ischemia. What they are saying, that there was an increased incidence of mesenteric ischemia, that is 5% versus 0% in the conservative therapy. And there was higher heart rate and a sign of increased mortality at 90 days in the conservative oxygen group, which resulted in early termination of the study. Thus, the conservative oxygen therapy or the strategy suggested potential harm. Maybe the reason is because in this conservative therapy, they have gone further down to 55 to 70 millimeter of Hg. So what they have said, what they are saying, that the conservative oxygen therapy is basically harmful. Now, I have made the list and of all the trials, most of the trials in the previous years. And if you see the results or the major finding of most of the trials. What the first IOTA trial says that they have compared the conservative versus liberal oxygen therapy, and what they found high mortality risk with liberal oxygen strategy. ICU ROCKS trial, no difference in 28 days ventilator-free days. Prospero trial, no difference in mortality or morbidity between lower and the higher oxygen group. Oxygen ICU trial, no difference in the SOFI score. LOCK oxygen trial, we know that it was prematurely terminated because of the increased mortality in the conservative group. Hot ICU trial, no difference in the 98 days mortality. So if we see all the trials, the result is more or less same. Impact trial, what they are saying that the PaO2 of more than 300 millimeter of Hg is significantly higher mortality, that is 63%, versus normoxia, that is 43 to 48%, versus hypoxic, that is conservative trial, this is 56 to 59%. So the minimum mortality is in the normoxic group. There are other different trials, and the more or less the results are same. No association between hypoxia and neurological outcome, no association with 6-month neurological outcome, no effect on 1-year outcome, no effect on 30 days mortality. So these are the trials, and the results are more or less same. So what we can conclude, or what should be our target, or what should be the perfect balance, is to maintain in a critically ill patient a PaO2 of 70 to 100 millimeter of Hg. Don't go beyond 100 millimeter of Hg. That is trying to maintain a PaO2 of 150 millimeter of Hg. It is not associated with good outcome. And the target of SpO2 is 92 to 96% of SpO2. Don't go for 98 to 100% of the SpO2. So these targets should be maintained or should be achieved in order to have a good outcome in critically ill patients. And more or less, it applies to all kinds of patients. Now, the point is how to achieve this target, how to measure the oxygen content in the body. Most of the point of this topic is discussed by the Professor Anil. But I would like to emphasize on the microcirculation, because what we see that systolic volume variation, pulse volume variation, cardiac output, SCVO2, all these parameters which we usually monitor and which we usually take into account in targeting our therapy, they are basically monitoring the macrocirculation. And it is definitely, it is a prerequisite that macrocirculation should be maintained in order to maintain the microcirculation. But the target is not the macrocirculation. The target is to maintain appropriate microcirculation, because it is the microcirculation which is actually delivering the oxygen to the required tissue, and it is improving the oxygen perfusion and improving the outcome. So the capillary circulation cannot be predicted by macrohemodynamic parameters. I will discuss in subsequent slide. Situations like septic shock or the heart failure, despite an optimal perfusion, macroperfusion, that is maintenance of the blood pressure, cardiac output, microcirculatory perfusion could be inadequate. Impaired microcirculation occurs due to multiple factors, which includes alteration in the blood viscosity, endothelial dysfunction, dicocalyx degradation, and or microthrombi or microaggregates in the microcirculation. So these factors are very, very important. And now we have gadgets and devices by which we can monitor the blood viscosity, capillary hematocrit, glycocalyx degradation, and many more things. So how we will monitor and how we will assess and analyze the microcirculation ICU in future? Capillary refill time, we are using it. The pressure application to the fingertips for at least 10 seconds until the skin showed whitening. The time until return of the baseline correlation after release of the pressure is measured with the chromometer. It is normally less than 3 seconds. And it is assumed that if the capillary refill time is less than 3 seconds, it means the microcirculation to the target organs, for example, kidney, splanchnic circulation, brain circulation, is also maintained. So it is a surrogate marker, more or less. The other technique which is very commonly used, and now they are trying to take this technique from the research to the clinical implication, especially at the bedside, near infrared spectroscopy. Tissue oxygenation saturation. What is the tissue oxygenation saturation? It is the oxygenation of the total hemoglobin which is present in that tissue, divided, it is the oxygen saturation of the oxygenated hemoglobin divided by the total hemoglobin present in that tissue. The strength of this investigation is non-invasive and easy to use. And when it is combined with the vascular occlusion test, the results are much more predictive and much more useful to guide your therapy. But it has also got limitation. That is, vascular occlusion test is used in the thinner muscles and in the forearm. And the result also varies depending upon the size of the probe, whether it is a 15 millimeter probe or 25 millimeter probe. So these are the challenges in the future, that they should be standardized, and what targets should be achieved, it should be standardized. Now, the other techniques by which we can measure microcirculation, I'm not going into the details of these techniques because of the paucity of the time. Contrast enhanced ultrasound, it is still in the research phase. Laser Doppler flowmetry, magnetic resonance imaging, nail fold video capillaroscopy, plethysmography, and veno arterial PCO2 gaps. What about gastric tonometry? Recently, in the near past, it was discussed very much, and the fluid therapy was guided based on the gastric tonometry and the sublingual microcirculation. It is assumed that the increased gastric mucosal carbon dioxide leading to gastric mucosal acidosis is a result of the anaerobic metabolism consequent to the splenic hyperperfusion. So what happens? The previous studies indicated that gastric tonometry is a highly sensitive predictor of outcome in patients undergoing cardiac surgery admitted to the ICU in sepsis or with acute circulatory failure. But there are several limitations. It has very poor specificity, secondary to multiple confounders such as inappropriate measurement of the stomach content PCO2. We don't know what is the PCO2 of the stomach content. So the diffusion process of the PCO2 may affect the readings. The temperature, buffering of the gastric acid by duodenal esophageal refluxes, difference in arterial supply and enteral field, all these factors are going to affect the mucosal CO2 of the gastric mucosal CO2, which will ultimately affect your management. Now the sublingual microcirculation, very much emphasized, and now it is assumed that if the sublingual microcirculation is adequate, then the microcirculation of the target organs is also adequate. How can we monitor? Handheld held vital microscopes, direct non-invasive real-time visualization of capillary network. Now, based on the software available, what we can monitor with the handheld vital microscope, we can monitor the capillary hematocrit, capillary density, capillary viscosity, and the glycocalyx integrity. The glycocalyx integrity can be monitored, that we can monitor the flow of the RBC. If we see in the images that the flow of RBC is not streamlined and it is going laterally, so it is an indirect evidence that the glycocalyx integrity is not maintained. And the glycocalyx integrity is very, very important factor, because it has been seen that in those septic patients or the critically ill patients in which the glycocalyx integrity is maintained, then the outcome of those patients is definitely better than those patients in which the glycocalyx integrity is not maintained. So I study, or what will happen in the future? The future says the capillary hematocrit, capillary density, and on the basis of the capillary hematocrit density and the viscosity, maybe in future we will guide our RBC transfusion therapy, our fluid therapy. That is, if the density capillary hematocrit is less and the viscosity is less, then we can plan, oh, this patient needs RBC transfusion. And if the capillary hematocrit is okay and the viscosity is medium, then we can say, okay, this patient doesn't need RBC transfusion, this patient needs fluid therapy. So this is future. A study by Ospina et al. Found that fluid administration can improve the microcirculation at early but not at a later stage of sepsis. What we have seen and what we have read and what the River et al. Has said, that a patient with the sepsis start fluid therapy with 30 ml per kg and then boluses. If not responding, then again give the bolus in order to maintain the CVPs, SCVO2 and all the targets which we already know. But what recently they have found, that usually the first bolus, it improves the macrocirculation as well as the microcirculation. But in a severely septic patients, the subsequent boluses, they are not associated with the improvement in the microcirculation. And one of the most important reason is that there is a transudation of the fluid, and which is increasing the tissue edema. Secondarily, it is causing the increased pressure and decreasing the blood supply to the microcirculation and to the target organs. Portecher et al. Showed that a first bolus, but not a second bolus of the fluid, improved the sublingual microcirculation independently of the stroke volume increase in the patient with septic shock. Now it is confirmed with the sublingual microcirculation that the first bolus increases the microcirculation, whereas a second bolus also decreases the sublingual microcirculation. Indirectly, it is decreasing the microcirculation to the kidneys, brain, and the vital organs. Transkunas et al. Reported that patient who had impaired microcirculatory perfusion that improved with fluid therapy had an associated improvement in the organ function, whereas patients who had normal microcirculatory perfusion initially or who failed to improve their microcirculation in response to fluid did not have an associated improvement. So what we can say, that with initial therapy, the oxygen delivered to the microcirculation and to the target organs, if the patient is improving with the microcirculation is improving with our fluid therapy or RBC transfusion, then it is assumed that this patient will have a definitely better outcome as compared to those patients who are not responding to our fluid therapy. That is, whose microcirculation is not responding to our fluid therapy. Mixed venous or the central venous oxygen saturation, very illustriously discussed by the Professor Anil sir. Extraction ratio and about the delivery of the oxygen and SCVO2. What just I would like to emphasize that oxygen extraction depend on the activity, tissue, and the mitochondrial function, and SCVO2 or the SVO2 is not does not assess the microcirculation. They all assess the macrocirculation. So SVO2 normally drops to 60% when extraction ratio is increased to 40%, and SVO2 may drop to 40% when the extraction ratio reaches to the maximum 60%, or what we can say that the normal extraction is 25 to 30%. It can increase to 40%, and the maximally the extraction of the oxygen from is increased to 60%. Beyond this, the body cannot extract oxygen. Then what will happen? If the extraction ratio is achieved to the maximum, any further demand lead to anaerobic lactate production, and which will lead to the inevitable shock. Interpreting SVO2, SCVO2 is more easily obtainable from the central line. We all know this. Increased SCVO2 may reflect two situations. Either there is an increase in the oxygen delivery relative to the oxygen utilization, or in a successfully optimized or the stabilized patient, so the recovery patient. On the other hand, it may happen that there is a mitochondrial dysfunction. So whatever oxygen you are delivering to the tissue is not able to utilize the mitochondria of the affected tissue is not able to utilize the oxygen, and that oxygen is coming back and the SCVO2 is maintained. Or inability of the SCVO2 to explore local, regional, or microcirculatory perfusion. Hypoperfused area contributes little desaturated blood to the venous return, whereas hyperperfused area will contribute to the venous return with a good amount of the oxygen saturation. So ultimately the total amount of the SCVO2 is normal, but actually the patient is deteriorating because you are not maintaining the oxygenation at the microcirculation level. So the normal SCVO2 should not be considered as the ultimate endpoint. So what I am trying to emphasize that the parameters or the things which we usually monitor, they are targeting the macrocirculation, assuming that if the macrocirculation or the blood pressure is maintained, then the microcirculation or the affected or the target organs oxygenation is also maintained. But this is not the case in every case. So we have to devise and we have to look for those devices which actually monitor the microcirculation. And on the basis of that monitoring and the data, we can target our fluid therapy, RBC therapy, or the now new drugs are coming up, like prostacyclin analogs, which have got the vasodilatory properties and antithrombotic properties. So what we have to see what is the basic reason behind decreased microcirculation, and we have to hit and target that reason, and definitely it is going to change the outcome of the septic patients. So to conclude, neither hyperoxia nor hypoxia, conservative therapy is better, still maintaining normoxemia. What is normoxemia? It is the PaO2 of 70 to 100 millimeter of Hg and SpO2 of 92 to 96% is the best strategy. Capillary circulation cannot be predicted by microhemodynamic parameters. Integrity of the glycocalyx seen with handheld vital microscope is a good predictor for successful outcome. In future, decisions to transfuse RBC fluid can be based on capillary hematocrit, capillary density, and viscosity. It is anticipated that handheld vital microscope may include sensors and imaging modules, possibly even embedded into the tip of endoscope or even digestible capsules to observe the microcirculation and the cellular constituent in distant organs. Artificial intelligence could allow us to establish these algorithms and help the clinician to make therapeutic decisions regarding the treatment of microcirculatory alterations. The challenges for the future is to have a non-invasive, easy-to-use equipment that allows for reliable assessment and immediate quantitative analysis of microcirculation at the bedside, so that the adequate oxygenation which we are maintaining in the circulation should be delivered to the target tissues and the patient outcome is improved. Thank you.
Thank you, Dr. Abu. I think it was a very complicated talk, which you tried to make it as simple as possible. I hope the audience can gather some knowledge on this, and if need be, we can discuss on this topic in subsequent time. So my talk, can I share my screen now? Yeah. So I'm Professor Moeed from Department of Anesthesia and Critical Care, Yale Medical College. My talk is a bit different, of course, which is in continuation with the previous speakers. I hope you have been able to visualize my screen.
Yes, sir.
Right? Slide is visible? Yeah, I can change my slide. So I bring, is it visible? No? Right. So I bring greetings from my university and my medical college. So I'll be speaking on oxygenation. Of course, this is one of the buzzword today in today's anesthetic management, because we've seen the demand and supply. We've seen the where we need to monitor. Actually, whatever we are trying to monitor is something which we are primarily not targeting, but because we target the microcirculation primarily. That is what is one of the most important components when you talk about hypoxia. And then we see how we deliver the oxygen deliver oxygen to different patients. But one of the most important thing, if you see that the serious risk encountered in anesthetic practice is hypoxia, and that has already been dealt with the previous speakers very nicely. And it is very common, and it is seen that around 18% of these patients, they suffer during anesthesia, which is less than SpO2 is less than 90%, and severe hypoxia is more than 10%. And consequences of prolonged hypoxia, you know, that it ultimately leads to brain damage. So this is the primary target we are talking about. And if you see this study which Tim Cook had did in NAP4, a study which was way back in 2011, he really made an eye-opening results, came up with an eye-opening results which said that majority of the mortality and morbidity was because of airway-related problem, and this was primarily because of failure to deliver oxygen to the tissues or oxygen during airway management. And this could be because of multiple reasons. Primarily, it could be because of, you know, those days we had a multiple went on trying to attempt for intubation, which probably is delaying your intubation and making hypoxia more common to the patients. You're not being able to use your supraglottic airway device appropriately. You're not being able to go with the awake fiber optic intubation, which is needed at a particular time. And overall, what ultimately, which is we are landing up to is the time management. We are not exactly trying to monitor the time which has elapsed, that we are not being able to oxygenate this patient, which is very important. And this has led to a lot of complications and morbidity. So if you see that primarily when you talk about pre-oxygenation, which we were always till date, till last a couple of years, we were always thinking of pre-oxygenation, something which is obviously preventing your hypoxia during intubation. But what we are targeting is primarily we are denitrogenating the patient's lung, and the endpoint we try to reach is if the patient has an E2O of 90% and the entailed nitrogen level is less than 4%. But this we can achieve, of course, by giving 100% oxygen before the patient is being intubated during pre-oxygenation. But this amount of oxygen which we are trying, which we fill up with the lungs, is primarily probably fixed amount, because once the patient becomes apneic, if we don't supply oxygen continuously, actually this will fall depending upon the patient's lung characteristics. And if you see that fall of oxygenation during apnea is very rapid, depending upon the patient's lung compliance, and it is inversely proportional to FRC. That means if the FRC is less, the fall is much more rapid, and this ultimately causes hypoxia. And so that means the patient's lung characteristics is very important when we talk about pre-oxygenation, and this ultimately will cause an increase in carbon dioxide depending on the time factor. So initially, when we talked about pre-oxygenation, we had different methods. One was deep tidal volume breathing, which was for 3 minutes, and we saw that we can maintain an oxygen E2O2 of 90%, and we can keep the patient apneic for a period of 4 to 9 minutes. That was maximum. And when we went on deep breathing, that is vital capacity breath, for 8 vital capacity breath for more 1 minute 30 seconds would obviously which was almost same to that tidal volume breath for 3 minutes, but it was not similar in case of 4 deep breaths for 30 seconds. So this is something which we always tried to achieve in the previous in way back around 5 to 10 years back, and we were still practicing those systems. And ultimately what we have seen is, as I've said before, that this was primarily for a patient who had a lung characteristic which was normal. But in patients where the patient is already, supposing in critical patients, especially intensive care unit patients, where we would like to intubate these patients, probably their lung characteristics is much more different. They have a FRC which is reduced, they have atelectic lung, they have pulmonary shunting lung. So in that case, obviously the apnea time is much more reduced when we talk about pre-oxygenation with the same system. So naturally, obviously the options which we have, as Mahima has said, that we could go for CPAP, PEEP, BiPAP during pre-oxygenation and probably increase the FRC and increase the oxygen reserve. But during intubation, probably will not be able to do will not be able to maintain the CPAP or PEEP or BiPAP. So naturally, when apnea subsets one you're trying to intubate, probably that will further, it will drastically come down with your oxygen level in the patient, and patient can decide very fast. So what is the buzzword now? So we think that probably if we can somehow deliver oxygen while we are intubating at the same time, that means the concept of pre-oxygenation is already there. So if you can come up with an apneic oxygenation, that means when the patient sets in apnea, when you induce the patient, we have relaxed the patient and we are trying to intubate this patient, probably if you can deliver oxygen during this period, probably the patient's hypoxemia or apneic time can be increased. So that is para-oxygenation, the term which has come up, or peri-intubation oxygenation. And obviously, as I said, methods could be during pre-oxygenation, we have seen the standard techniques, and apneic oxygenation will come to this later subsequently. So what is the physiology of para-oxygenation? One of the most important thing is, if you see it is something to deal with aventilatory mass flow. That means when the patient is being apneic, so we know that in a patient's alveoli, we have 200 ml of oxygen, which is there. And out of this 200 ml of oxygen, per minute, around 230 ml of oxygen is being extracted, which is diffuses into the circulation. And that means, and from the circulation, from the capillaries, only 20 ml of oxygen goes inside the alveoli. That means there's a negative pressure or gap of 230 ml. Now, this negative pressure can create a gradient, pressure gradient, which will cause an influx of oxygen air from the atmosphere. So this is primarily one of the most important physiology which works with when we talk about para-oxygenation. But if you are giving air during this period, probably that will again cause an renitrogenation of the alveoli. So if you would like to go for an oxygen supply during this period, you give high flow oxygen, probably that could prevent the renitrogenation and the apnea time can be increased. So this is one of the most important thought process or physiology when we talk about para-oxygenation. So when the patient is apneic, pre-oxygenation is already done, you have already denitrogenated the patient's lung, and then subsequently when the patient takes, because of the patient's apnea, the patient has the extraction of alveoli from the alveoli, there are around 230 ml of 250 ml of oxygen goes inside and 20 ml of oxygen comes out. So naturally, there's a negative balance of around 230, which probably cause a negative pressure gradient, and there could be flow of air, if provided the patient has an airway pit. So para-oxygenation is primarily, which we are talking about, why do you want to have, is we want to have a safe apnea time, and this can prevent the anesthesiologist from hurrying up. And we have from the concept of stop and start approach, we can go with a smooth and unhurried approach of dealing the patients while intubating. So this is one of the most concept which has come up while we talk about para-oxygenation. And as Mahima has already said, that obviously with low flow of oxygen, nasal cannula, we can, around 5 liters per minute, we can increase the duration by 5 minutes, and we can increase it to 4 to 10 minutes. We can give our 3 to 5 liters per minute nasal catheter. But you can increase the time period of apnea more when you go for an intratracheal catheter, or we can go for a high flow endobronchial catheter, or we can go for a high flow intratracheal catheter, which can increase the apnea time to around more than 20 to 30 minutes. So the different techniques which we already said, Mahima has already dealt with it. One of the most important things is no DSAT, which Richard Levitin came up with this concept, which is known as nasal oxygen during efforts securing a tube. This is no DSAT, with Richard Levitin came up with this study. Thrive, of course, was again, which was putting, old wine in a new bottle. The concept of Thrive, which you talk about, which is transnasal, high humidified, rapid insufflation of ventricular exchange, direct pharyngeal insufflation, which is already talked about, nasopharyngeal catheter and buccal oxygenation, and other is, of course, intratracheal catheter, endobronchial catheter, and so on and so forth. So, but one of the most important prerequisites is whenever you're talking about this oxygenation technique, very importantly, you must see that the patient's airway is patent, adequate pre-oxygenation has already been done, and placement of a device or deliver catheter and oxygenation should always be very important in these patients. Now, this is a landmark study which was reported by Anil Patel, who did a study on an observational study, which is cross-sectional study on 25 adult patients, where he saw where he delivered during the after induction, during the peri-intubation period, he gave 70 liters of oxygen during induction and prior to induction as well, and saw that what is the heart rate, saturation, oxygen saturation, and carbon dioxide. He monitored that, and what he found was that the mean apnea time was increased to 14 minutes, which was around 9 to 19 minutes was the range, and there was no patient who desaturated less than 90% saturation, and the apnea time did not cause any sort of cardiac irregularities. So this is very important, and because they did not cause any oxygen toxicity. So this study was one of the landmark studies, because of which was way back in 2014. He reported, and because of this, we started off thinking of the eventually Maslow and Thrive during your paroxygenation. Now, this is again an Indian study where they did the study on the mean oxygen partial pressure of oxygen depending upon the time, apnea time, and what they found was that during apnea period, time to desaturate of less than 90% was statistically significantly prolonged while giving Thrive during this patient. So naturally, if you give Thrive during apnea, probably you're going to increase your apnea time, and that obviously gives a safe time to intubate it. Now, this is a systematic analysis, which is very wide, huge study from a Cochrane study around dealing with around 1,800 plus patients. They did it in around 6 ICU and 6 emergency department with 2 combined emergency and ICU. So it was a huge study, and it was reported in Annals of Emergency Medicine in journal. And what they found out is, I will not go in detail, but I'll try to report it. They did a forest plot, and then they said they compared it. The lowest oxygen saturation during peri-intubation was which favored apneic oxygenation. That means when you do an apneic oxygenation, actually the saturation during peri-intubation did not fall less than 93%. So that was again a very important finding during this meta-analysis. Subsequently, the patient's first pass success was that means the people anesthesiologist who did an intubation was very cool and calm, and they did not have any problem while intubating this patient. The first pass success rate was very high, and which favored apneic oxygen as well. And hypoxemia did not fall less than 93%, which again was because of apneic oxygenation. And severe hypoxemia less than 80% again favored apneic oxygenation. So there was no severe hypoxemia as well in these patients. And life-threatening hypoxemia is also not to that extent, which they really favored a patient with an apneic oxygenation. So that means, which tells us that during intubation, probably when we are trying to intubate this patient, when the patient is apneic, before that, of course, we have gone for a pre-oxygenation. During apnea, obviously, if we can give some amount of oxygen either in the form of low flow around 5 to 10 liters or 10 to 15 liters, or a high flow nasal cannulation, because this is the time where what happened is, because when you give a high flow cannula oxygenation, you're giving supposing the pressure of a flow of around 70 liters, means per 10 liters, it increases your pressure, intra-alveolar pressure by 1 centimeter of water. So that means when you're giving a CPAP, when you're giving a flow of 70 liters, you're giving at the same time a CPAP of 7 centimeter of water, which obviously opens your alveoli and prevents the alveoli to collapse. So it also adds to your atlectic patients, where probably the apneic oxygenation will always keep your alveoli open and help to oxygenate this patient. So this is again one of the most important components when we talk about high flow nasal cannulation or Thrive. So the clinical applications obviously is an emergency intubation, where we think the patient needs to be intubated fast and rapidly and without any hypoxia as well, because we know that these emergency intubation could be a situation where the patient is critically ill or the patient is already having some lung problem. So that in that case, obviously, the paroxygenation concept can help. Routine elective and endotracheal intubation, obviously, it is going to help. Bronchoscopy is again a component is important. When we do it, especially in cases critical patient, intensive care unit patients, where we are trying to do a bronchoscopy. These patients are already having a lung characteristic, which is much reduced, lung reserve, which is much reduced, probably if you can go ahead with an apneic oxygenation, that can obviously prevent the patient from hypoxia. And there's a concept which has come up, which is a tubeless anesthesia, where probably in ENT patients, ENT surgeries, we always give we do some sort of biopsies or some sort of examinations where we can go with an tubeless anesthesia giving apneic oxygenation. Of course, difficult airway management is always an added advantage when we talk about apneic anesthesia, because we are not worried about the apnea. We give a lot of the apnea time is with us, and we convert our technique of stop and start approach to, obviously we have a smooth and unhurried approach, and we get a lot of time and the patient is not hypoxic. But that does not mean that you go on fiddling up with the airway, creating a lot of problems. So critical care, obviously, as I said, is one of the most important domain where probably para-oxygenation can help. And if you see, even in the recent guidelines by ASA 2022, they have already emphasized that the optimization of oxygen, which is during the intubation period as well. So this has already been highlighted by the difficult airway guideline with the ASA, where it is important to think about para-oxygenation as well. So even the Indian guidelines, they have also emphasized this, that especially in critically ill patients, intensive care unit, when you're trying to intubate this patient, because the patient is already probably on an NIV or on high flow nasal cannulation, so you cannot convert this patient into just bag and mask ventilation, because the patient needs a high pressure, high CPAP or high PEEP. So during your intubation, you can maintain that pressure to a certain extent while intubation with an apneic oxygenation, with a high flow nasal cannula oxygenation. So this has again been emphasized in this patient. But remember, this is not free of complications. There could be a lot of complications, especially we talk about respiratory acidosis because of the increased CO2, which we've seen that per minute we can increase a 3 millimeter of rise of CO2, which can range from 3 to 16 millimeter of 8 millimeter of mercury. CO2 can rise. So actually that has to be taken care of, and one has to monitor that very importantly. And the barotrauma, again, because of your flow of oxygen which you're giving, that can be a problem as well. And then accidental awareness, because you're not being able to take care of the sedation component, and hypercarbia because of carbon dioxide increase, that is again a problem. But this ultimately can cause a lot of respiratory acidosis and cardiac arrhythmia, and ultimately result to cardiac arrest. So one has to be very cautious when we're going with apneic oxygen, and it is not free of a problem. So there could be an algorithm which you can follow, which obviously Mahima has dealt with some of how to administer. So I have just made it in a plan A, plan B, plan C, which we always think of. Plan A is if the nasal cannula at 15 liters per minute plus non-rebreathing face mask at 15 liters per minute could be a component when you talk about plan A. That is the plan A. If you fail, or if you don't have this with you, then you can think of plan B, which is nasal cannula 15 liters per minute plus a bag mask valve with PEEP valve. We can go ahead with it. And if you don't have it, or if it fails, then you talk about plan C, which is nasal cannula 30 to 45 liters, which we talk about high flow nasal cannulation. So plan A, plan B, plan C, depending upon your patient's characteristics and what patients you're dealing, at the same time what is available or limitations within your with your operation theater or intensive care. So to summarize, we have already seen Dr. Anil has very categorically emphasized hypoxia, which is one of the commonest cause of mortality during anesthesia. There always must be a balance between them, demand and supply. He's already emphasized that. That very importantly, you must know what is the demand, you must know what is the supply, and that can again talk about extraction and supply ratio. So, but Dr. Abu Nadim has very categorically mentioned one very important thing, that probably what we are trying to see, what we are seeing, that is not exactly the surrogate what we are talking about at the microcirculation. So naturally, we have to, when we talk about the oxygenation level, we are seeing the blood pressure, we are seeing the oxygen saturation. Probably that is exactly not being reflected at the microcirculation. So we need to target the microcirculation when we talk about hypoxia, and we need not be thinking about hyperoxia, which is again detrimental to the patient's overall outcome. So obviously, we better to maintain a normoxia at the range of 70 to 100 millimeter mercury, which is good enough for the patients to keep to maintain. So that's what we are targeting. Second is obviously to deliver. When you talk about giving oxygenation, where we know the target, we know the critical level at the tissue level, but we need to deliver this. So we must know how to deliver this, because if you don't know what amount of oxygen will deliver with what system, what definitive techniques will deliver what percent of oxygen. If you don't know that, probably will not be. Say, for instance, if you don't know that what BiPAP does, what CPAP does, what high flow nasal cannulation does, if you don't know how beneficial it is to which patient it is beneficial, then probably you'll not be able to target your oxygen. So naturally, you must know the system, the delivery system of oxygen, when you are implementing or applying this delivery system to a particular critically ill patient. So you must know the lung characteristics, you must know the delivery system while you're trying to. So that has been very nicely dealt by Dr. Mahima. And obviously, what I have seen that the NAP4 has really raised our eyes, opened our eyes, and we must see that most of the complications, what we talk about in and around the operation theater, is primarily airway related. Even in the intensive care unit, when we talk about intubation, is because primarily related to intubation, and that is more predominantly when we're talking about induction and intubation, where probably we cannot make the patient keep away from hypoxia if we only restrict ourselves to pre-oxygenation. We need to think about today's buzzword, which is para-oxygenation, which is very important because that is the component which is going to increase your FRC, increase your lung volume, increase your oxygen reserve at the time of intubation as well, and give you a more safe apnea time. And this it always works as the A1P mask flow oxygen. So you need to keep the patient's airway patent, go on continuously giving oxygen without keeping the patient hypoxic. And obviously, you can convert this when you talk about action to stop and start approach to a smooth, unhurried approach, which obviously will have a better outcome when we talk about airway management. And the best technique when we talk about para-oxygenation is high flow nasal oxygenation or TRIVE. Thank you so much. So this is a journal we are coming up with. I would request all the delegates to submit articles, even my faculties to submit articles as well. Over to you. Thank you so much. So any questions? I think we can deal with it. Over to you, madam.
Yeah, are there any questions, Mithilesh, in the chat box?
Yes, ma'am. We have 3 questions in the chat box.
Yeah.
I have already replied one of the questions, which was there.
Yes.
And I think Mahima has also tried to answer that question. Let me see.
Right. So anything left? Are they all answered?
Ma'am, last question. One is by Dr. Muthukumar. Too much of denitrogenation, will it not produce more atelectasis, which will produce post-pulmonary complications?
So naturally, when we talk about too much of denitrogenation, what do you mean by this too much of denitrogen? Means you are trying to remove your nitrogen from the lung component, which is 78% of the lung has nitrogen. But this is for a very short period of time. So when especially when we talk about the high flow nasal oxygenation or TRIVE, and this is not going to cause atelectasis. The reason, one of the most important reasons, is because it simultaneously is delivering a CPAP of 7 centimeter for if you're giving about 10 liter of oxygen, you're giving at 1 centimeter water pressure. So atelectasis is not a problem, but yes, if you go on doing this for a prolonged period of time, probably it can cause atelectasis. But when you're talking about intubation period, so it is ranging from a period of 4 to 9 minutes, maximum 10 minutes or 20 minutes. Probably that would not cause any sort of atelectasis to that extent. But most importantly, when we talk about atelectasis, so that is a subsequent problem. The initial problem is the patient should not have hypoxia due to intubation, during intubation, or failed intubation. So that is the primary target we are talking about. Initially, we have to think about that the patient does not go to hypoxia because of oxygen.
That's right. Any more? No more questions? Mithilesh, I don't think so.
Not in the chat box, ma'am.
Right.
We can, yes.
So, thank you so much for this excellent webinar. The topic sounds such a basic one, but all the points that have been covered, they were so valid, and rightly so. Para-oxygenation a few years back this terminology was not really known. But since now it has come in the books, it is so beneficial. We are all using it, and we teach our students that right from the beginning of the case, do this, give this para-oxygenation. So all type, even the oxygen delivery devices, basic things asked in the exam, and the children should know it even in their daily practice. So Mohit, thank you so much for conducting this webinar so well, and of course taking the lecture as well on para-oxygenation. And thanks a lot, Dr. Anil, Dr. Nadeem, and Dr. Mahima for contributing and making this webinar so successful.
Thank you. madam.
Mitlesh, Mitlesh, thank you so much
Thank you,
for
ma'am.
hosting the thing. And thanks a lot, everybody, and hope to see you very soon, sometime or the other. And do join us in the annual conference. Anil will be there, I know. And please do. Yes, of course.
I'm conducting the airway workshop. ma'am.
Yes, so we'll be seeing you all in September. That's great.
Thank you.
Shreyashi, thank you so much for Clarinet for hosting us. Good night, everybody, and see you all next week
Thank you,
for
ma'am.
the
Thank you.
198th program. Thank you.
Thank
Good
you.
night.
Thank you. Thank you, Mohit sir.
Okay.
Thank you, boss. Thank you, sir.
Okay, sir.
Thank you, sir. Thank you, Anil boss.